We're supported by Panacea Financial, digital banking built for doctors by doctors. At Panacea Financial, you can have your own free personal banker and a support team that works around the clock just like you do. Open your free checking account today at panaceafinancial.com. Panacea Financial is a division of Sonabank, member FDIC.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back.
Hey, Matt, how you doing?
This is the Curbsiders. That's the great Dr. Stuart Brigham interrupting me as usual. The great Dr. Paul Williams is also here. Tonight we are talking about chronic cough with Dr. Brad Hayward. And before we get to that, I wanted to remind you that this and most other episodes are available for free CME and mock credit through our partnership with VCU Health Continuing Education. You can go to curbsiders.vcuhealth.org and set up a free account. So with that, Paul, would you tell the audience, what do we do on this show?
Happy to. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And as you mentioned, tonight we talked to close personal friend, deep mentor from our residency training, the great Dr. Brad Hayward. And I'm going to let Cyrus tell us all about the episode and about our special guest.
Awesome. Hey, thanks, Paul. So tonight we were thrilled to record an episode on cough with our guest, Dr. Brad Hayward. Dr. Hayward is an assistant professor of clinical medicine at Weill Cornell Medical College in New York City in the Division of Pulmonary and Critical Care Medicine. He serves as an APD for the PCCM Fellowship Training Program. And additionally, he has pursued fellowship in palliative medicine, holding a dual appointment in the Division of Palliative Medicine. His goals are to combine and further the fields of pulmonary and critical care and palliative medicine. And in this episode, he teaches us about the common causes for subacute and chronic cough, how to diagnose the cause for cough in these patients, and how to approach therapy. So without further ado, let's get it on.
Excellent. Hey, Paul. So, did you know there's actually a new term for the arts in this COVID era following postmodernism? It's called Kafkaesque.
You didn't even give me a chance to respond.
I know.
And you already got a pun in.
Yeah, sorry.
All right.
Kafkaesque.
All right, fade to black.
Brad, thank you for joining us. We've been talking about doing some pulmonary topic with you for a long time now. I'm glad for the audience to meet you. So tell them a one-liner about yourself and give them a hobby or interest outside of medicine.
Sure. So I'm a 39-year-old pulmonologist, intensivist, and palliative care doctor who's dedicated to teaching practical aspects of my fields. My social history is notable for curating an Instagram for my dog Arnie, watching trashy reality TV shows, and sometimes running marathons, but often claiming that I hate it.
What kind of trashy reality TV shows? I've got to ask.
Well, as you know, there's many, but 90 Day Fiancé is currently on loop, and there's that, Below Deck Med. The options are endless.
So yeah, normally, and I'm still going to ask about a book, even though in the interest of full disclosure, I may not get to it until 2024, if the world survives. But in the short term, I would like to hear more about Below Deck Med. Now I am fascinated. So what is that?
Well, there's apparently this whole world of super rich yachters, and it's like set in the Mediterranean. That's the med part, and then it's about the cast that is below deck that takes care of all these super rich people. They're called yachties. They come from all over the world, I guess, to work on these super yachts, and there's always, of course, a lot of drama below deck. So that's pretty much the premise of it.
That's much better than when I thought it was actually medically related. I'm actually much more interested now than I was previously. That sounds great.
Yeah, no, it's strictly superficial and trashy.
Oh, perfect.
For the audience, Paul does not like any medicine in his downtime. It's pure escapism.
That's
Correct,
good. Yeah,
Paul?
no, that's similar.
Yeah, no, even in my professional life, I really try to minimize medicine as much as possible.
So, were we going to get a book then too? Or?
Yep.
Yeah, favorite book?
my favorite book.
Actually, I think we normally frame it as a book that doctors should read. So either one is a valid option.
Yeah, I mean, the book that I think that all doctors should read is one called Mastering Communication with Seriously Ill Patients by Anthony Back and Bob Arnold. And it's essentially like a roadmap and an outline of the approach to having palliative care type discussions with patients. And it also provides you a way and a framework of addressing patients' emotions, which I think is really challenging for everybody. And it can work outside in terms of addressing like friends' emotions or other people. So I think it's a pretty good book and I would recommend it.
Yeah. So what's the best advice you ever received as a learner or as a teacher?
I think the best advice that I've had as a learner in terms of working with patients is that we have 2 ears and 1 mouth and to use them in that proportion. So it's hard to listen sometimes to patients when we have a short period of time or you want to start asking questions like about cough or other things. But I found myself, if I deliberately don't say anything for a period of time, it actually is more efficient in the end and they sort of tell you their story. So I try to keep that proportion in mind. So I think that's probably the best advice I've had.
Our sponsor today is Panacea Financial, the financial remedy for doctors created by doctors. With nationwide digital banking, Panacea Financial provides physicians and medical students with free checking, a personal banker, around-the-clock customer support, and loans designed with you in mind. No one should borrow money more than they need, but with Panacea Financial, physicians in training can get money as needed in as little as 24 hours with their PRN personal loan. It has an interest rate that is less than half the average credit card, no cosigner requirement, and a fully digital application. Instead of running up credit card debt, try their PRN personal loan that is designed to give you a better way to cover expenses such as relocation, board exams, or even home renovations. In addition, physicians in training can have a period of no or reduced payments on their PRN personal loan. Go to panaceafinancial.com today to learn more. Panacea Financial is a division of Sonabank and member FDIC. Paul, could you start us off with a case from Kashlak Memorial?
Sure. Happy to. We went all out with a name on this one. So I'm going to tell you about Ms. Esmeralda Wheezy. She is a 33-year-old female. She's presenting to her primary care provider at Kashlak Memorial for a cough. She states that 6 weeks ago, she had a week of intermittently productive cough. She felt easy fatigability. She felt congested. She had some sinus pain along with some chest pain with deep breaths. She went to an urgent care and was diagnosed with bronchitis. And after about 10 days or so, she felt more or less back to her baseline, with the exception of a cough that has persisted. So she's coming to us now, hoping for some kind of relief and also an explanation as to why she still has a cough. But before we save Ms. Wheezy, I think it's probably always helpful to define our terms. So I wonder if you wouldn't define for us, especially in terms of the timing, cough and sort of how we should conceptualize it.
Sure. So acute cough is cough less than 3 weeks. Typically, that cough is like a viral respiratory infection. So that's usually the only cause of acute cough. And so we typically don't go much further in our investigation of the cause if that's the timing. Subacute cough is 3 to 8 weeks, and chronic cough is greater than 8 weeks. And that's where there's the large differential diagnosis. But for acute cough of less than 3 weeks, it's usually a respiratory infection, and we don't do much about it.
Brad, I think that's one of the hardest things when you see patients when they're in the midst of it, like that first 3 weeks or even that first 8 weeks where they're really like worried about this cough as the thing that's persisting. And probably since you're getting referrals, you probably don't see the patients in that period as much. But usually one thing that I try to tell people when they're in the midst of like a cough or cold is probably the cough will be the last thing to go away. It should go away by the 8-week point. I'm not sure if you have a way that you approach that.
Yeah, I mean, we don't always see them in that acute period, but I try to set the expectations with the patients ahead of time is that, this is going to be a process that's, it's irritating and it's annoying to not be able to get rid of this cough, but eventually we may find a cure for it and it may just get better on its own. But just setting the expectation that it's not something that we're going to be able to fix overnight, even if we do figure out what the etiology is. So it kind of manages their expectations ahead of time.
Brad, we always like to really dig in deep to ask what what part of the history do you really key in on when you're seeing a patient like this? Because I think that's in primary care, certainly that's within our wheelhouse. So what is important about cough? I mean, patients, we were talking to a doctor, an otolaryngologist about sinusitis, and she was telling us that patients bring in like tissues filled with snot to her office. And I imagine similar things may happen with chronic cough, like people bringing in like a fresh loogie, if you will, for you to inspect. Is that helpful? And if it is, or if it isn't, like what is helpful when you're asking people about cough and you're evaluating it?
Yeah, I mean, it's not helpful when they bring in the tissues filled with sputum, in a big garbage bag that they've been collecting. So it's not helpful. But
You're saying that's happened to you?
many times, yes. So, yeah, I mean, even though, I'm comfortable with sputum, it's really not that welcome. But in terms of history, some of the things that are important, especially because if the patient is coming to me as a specialist, they probably have been thinking about this for a while. So some of it is just letting them go and say, just tell me about your cough, because they've already started investigating, like, oh, I notice it happens when I eat gluten, or, when I'm around my grandchildren or something like that. So really just letting them tell you and say that there's not really anything, that would be weird or out of bounds, just so that they'll be able to freely share. But things that are really important are, have you had this cough before? Have you had any recent respiratory infections or illnesses? So did you feel like you had a cough or cold or anything recently? Is the cough productive or not? And the reason that can be helpful is if it's a productive cough, then we think of things like bronchiectasis or sinus disease. And if it's non-productive, then, could it be related to medications or intrinsic lung disease itself? Asking patients about a history of asthma is important. And one of the things that I usually do with that is that when they say they have a history of asthma, asking them, how did you get that diagnosis? Like, did you do pulmonary function tests, like breathe in and out of a tube? Because it seems like everybody at some point in their life gets a diagnosis of asthma without actually having asthma. So I always am very skeptical about that diagnosis. So asking them about, do they actually have asthma? For example, do they have like atopic symptoms? Do they respond to bronchodilators? Have they been on inhaled steroids before? Have they been hospitalized? Do they visit the ER often for episodes of bronchitis? Like those things might be consistent with asthma, but just having a history on your chart doesn't necessarily mean that it's the truth. Asking about seasonal allergies. So, do you get itchy eyes? Do you have itchy skin? Other things, around the change of the seasons, like either in the spring or the fall. I do ask about reflux symptoms. So, do you ever notice when you lay down at night that you have heartburn? Do you have like a bad or sour taste in your mouth? And then asking them when they notice this happening, not necessarily just reflux, but in general, the cough. So do they notice it more in the morning? Do they notice it more at night? Do they notice it more when they're in their workplace or when they're in their apartment? Did they notice it when they moved their environment? Because at least in New York, people move apartments pretty frequently. So sometimes it can be associated with a change in their environment in that sense. So that's some of the questions. And then, of course, additional questions would be looking at their medication history. So are they on an ACE inhibitor or not? Because that can be a frequent cause of cough. And
only you're so lucky that that's why they're coming to you.
Yeah, it's happened maybe once, and I felt very, I felt very good about that, of picking that up. But most of the time, I think the referrals, at least, I think most primary care doctors are pretty quick to take them off of the ACE. So
it's like that, or if they're still smoking, you're like, all right, please go away. Come back when you're not smoking, and then we'll talk.
Yeah.
And I guess we'll get more into it. I wanted to ask about the GERD as a cause. I feel like I almost try to will my patients into admitting they have reflux because then I can give them something. Like, do you have heartburn symptoms? No. But I mean, you've had heartburn at one point in your life, right? And they're like, yeah, I do. Like, great. Then 2 weeks of PPI. Let's see how we do. But I feel like, is that...
That kind of begs the question if NERD is a thing too. The non-erosive reflux disease. Great stuff. But how high yield is
is the GERD, or at least we're trying to gun down GERD? Like we think about silent reflux sometimes. I know we'll get to management, but is there any even utility in just trying the PPI approach, or is that sort of frowned upon in pulmonary circles?
No, I mean, it's very, I don't know if I'd say encouraged, but they don't necessarily have to have a symptom of, acid reflux, or even, if we suspect silent reflux, because I'm not sure if we're talking about it during this part or not, but one of the etiologies is not necessarily that the acid is coming up in their throat and going down into their trachea. It's that there's like crosstalk between the nerves in the esophagus and the trachea. So they could be getting irritated in the esophagus from acid, but it's generating as a cough. So they're coughing from that sense. So we do a trial of PPI, whether they say they have acid reflux or not, if it's on the differential.
What I find crazy about the whole PPI thing, and also kind of depressing, is that when you read about it, they have to be on it for like 2 months, maybe 3 months, like a good trial. And it might take a very long time for it to go away. So it's probably hard to get patient buy-in there. And then even if that is the cause, the cough might not get, even if they do have reflux, the cough might not get better. So it's just, it seems like a real pain to figure that out.
On the contrary, yeah, I mean, on the contrary, it might get better, not because of the PPI, and you can at least take credit for that. So that
it just got better anyway.
Yeah. So, and they think I'm, the genius who picked it up, but
right.
It just got better. It's just the tincture of time and maybe a PPI. So,
okay. So it sounds like you take a pretty thorough history. You were giving us a big differential there, like seasonal allergies. We talked about GERD. You took a pretty thorough history about asthma, and then also you're asking, like, are they on an ACE inhibitor? I mentioned the smoking thing. So that's kind of the high yield area to start. This specific patient, Esmeralda, Miss Wheezy, she had about 6 weeks ago, she had what may be a viral infection. So how do you counsel this type of patient if they happen to make it to you in that 6-week time?
I think we just explained, similar to what you said you explained to your patients, is that the cough might be the last thing to go. So you may feel better from, the malaise or fever that you had, but the cough usually can linger for over 8 weeks after a viral infection. So this would be like a post-viral cough syndrome. And that can come either from rhinitis, which is upper airway cough syndrome, where there's postnasal drip and dripping down the back of your throat, or it could just be that the airways become more sensitive and so more easily triggered during that time. And so afterwards they may cough, like when they go out in the cold or when they're exposed to someone's strong perfume or other things like that. So I think in counseling them, it's just it's going to take time for it to get better, and that it's related, just explaining what I did, that it's related to the virus and it's probably the last thing to go.
So what sort of therapy, if any, should we offer a patient like this if we think it's a post-viral cough, like the time course meets up and they're at the 6 to 8 week mark, or let's say they're at the 8-week mark, and they're like, what can I do? We did a recent, I'm not sure if you follow our hotcakes series, but we recently talked about this meta-analysis where they looked at honey, and certainly lots of limitations there. And I'm not sure I fully believe it. Maybe there's something there, or it's just from what I was reading for this cough episode, it seems like anything that can potentially like soothe the throat and let it cool off seems like maybe that's how it works. But what's your approach, and what do you tell people?
I mean, I don't have a feeling about honey in particular, but I think for most of the patients, I ask them, this will probably get better with time, but how disabling is this to you? Like, are you coughing at work all the time that this is, so bothersome to you? Or are you willing to try medications? Because some people, surprisingly, even though they come to us, they just want an explanation but don't want medications. But for the most part, when they come to us, I'm assuming that they want some sort of treatment. And so I usually will ask them about whether they're having postnasal drip or sinus congestion or not. And if they are, then I would give them an intranasal steroid. And then I also would give them an inhaled steroid to help with reducing that inflammation in their lungs and that hypersensitivity for about 4 to 6 weeks. But the variable there is the intranasal steroid or not.
No, that doesn't matter what their flow loops show, with or without obstruction. You would just give it to them regardless for about 4 weeks.
Yeah, because I mean, it could be the cause could be obstructive lung disease, which would be asthma, or it could be an eosinophilic disease, which doesn't necessarily have to have obstruction, and the treatment would be the same, which is an inhaled steroid.
And again, we think this is a post-viral, right? So are we saying that induced like a reactive? We were saying that induced a reactive airways, not necessarily this person's going to have chronic asthma from now on. And would this person even, because this is like the first 6 to 8 weeks after an illness, would this person, I think Stuart probably wouldn't even have PFTs yet or spirometry yet. Okay.
I feel like something I see done fairly commonly in clinical practice is patients who are diagnosed with a post-viral cough get a short-acting beta agonist. They're just given albuterol. I've heard explanations like it helps sort of get the mucociliary elevator going, or it helps sort of decrease the airway responsiveness. Is that something that is actually useful from an evidence standpoint?
I mean, I think from a clinical evidence standpoint, I think that by the time the patients are coughing and then they use their albuterol, I think that it's not as effective. So that's why I think using an inhaled corticosteroid is more helpful, just for that longer acting effect. Because if they have just a few episodes of coughing a day, by the time they take their albuterol, like the coughing fit is already over. So I think using the inhaled corticosteroid as like not prophylaxis, but just as a continued treatment.
Yeah, maybe like if they were saying that they're a runner and they're starting to cough in the cold air, do you find that helpful to give it before they go for a run in this situation, like the short acting beta agonist?
Yeah, I mean, if that's all that they're noticing, or if it's this post-viral cough syndrome and they just notice every time they go out into the cold, to walk to the subway or whatever, they cough and it really bothers them, then I would say, sure, you could use just the albuterol then. But otherwise, I think an inhaled corticosteroid would be helpful for this, period while we're trying to resolve the inflammation.
And I just want to ask about the post-viral cough syndrome. Does this also apply to the world's most famous virus, COVID-19? So for like the post-COVID-19 cough syndrome, is there any evidence or any looking at inhaled corticosteroids for those patients?
For those patients, I mean, the ones that I've seen, a lot of times we'll give them just a course of oral steroids like prednisone for 5 to 10 days, because usually the involvement that they've had, and I have a select population, right? Because I only see people who maybe have come out of the ICU. And so if they're coughing, then I would give them oral steroids for, 5 to 10 days. But if it's somebody that you suspect had COVID and they still have post-viral cough, I think an inhaled steroid is reasonable.
Okay.
All right. So for Miss Wheezy, she sees, we send her to you for her post-viral cough. She gets inhaled corticosteroids and she also gets a nasal steroid. And what do you know? Within the next month, she's better. But I think we have a continuation of the case, or a new case here. So Stuart, did you want to read this one?
Sure. So next case is Mr. Winston Wheezy. He's a father to Esmeralda. He's a 58-year-old male who you see a few weeks later also complaining of cough, not unlike his daughter. However, unlike his daughter, he cannot think of any causative factor for his cough, just saying that his wife has been bringing up his coughing for the last several months. He's finally getting to the doctor's office to discuss it. So for this patient, how would you approach him differently than his daughter?
I mean, first the question would be, what is it about the cough that brought you in? Is it just because your wife was nagging you, or sometimes people might have a cough and then it has changed in quality in some way. So just trying to figure out what is the reason that brought you in today as opposed to last week. Like, is it getting worse, or is there something about it, that's in particular that we should address? But if there's nothing, that comes from that, then I would start thinking about, the top 3 causes of chronic cough, which is postnasal drip or upper airway cough syndrome, cough variant asthma, or GERD. And so I would start thinking about that in terms of questions that I'm going to ask him about his history. Yeah. And then also make sure that he didn't have any recent infectious symptoms, so that this couldn't be a post-viral cough syndrome.
Yeah, you just did a really good job with his daughter, and he wanted to come and see you too. That's really why.
Brad, I did want to touch on.
Oh yeah,
go for it, Paul.
I wanted to ask, I mean, we went over your history, taking the things that you emphasized in the last case, but I did want to actually touch on what environmental exposures you ask about specifically. Like say if a patient doesn't really volunteer anything, what are the very high yield things to ask about, especially in chronic cough, that might be good environmental exposures to know?
Yeah, so I mean, one would be asking. I mean, I feel like I'm probably failing my pulmonology colleagues by not emphasizing enough some of the social history. But what does he
Just
do
give me a chance for birds here, Brad.
So yeah, do you have any birds? And that's of course one of our favorite questions. But other history exposures would be like, what do you do for work? Are you a like a sandblaster or something like that, or are you somebody who works at a construction site where there could be asbestos or just exposure to dust? And that's some of the environmental history that we might go on. But then also, like in your house, do you notice, is there mold in your house? Have you seen like in the corners of your shower or bathroom or in your ceiling tiles or something like that, like watermark?
How about the last time you changed your filter in the house too?
Yeah, and so like, do you have air conditioners? We could go on and on about the different things that are going on in their house, and then what their work environment is like, what their home environment is like, and even going on the birds, like do you sleep with pillows that have feathers in them? Do you have down blankets? So it can be pretty revealing what people will tell you in the social history.
I should point out to the audience, if they want to hear us hate on some birds, the ILD episode written by Dr. Paul Williams and company was pretty. We really gave it to the birds on that one.
Yeah, they've had it good for too long.
Oh man, I had a thought. Oh, I know what I thought, Paul. This is what I thought you were going to ask about, which was the physical exam. And
oh gosh,
so
sure.
we really didn't go through the physical exam for the first case because the history was pretty much like a slam dunk for us there. But by the time someone gets to you, Brad, I imagine you have to think maybe this could be something other than like the big three, the upper airway cough syndrome, cough, air, and asthma, or GERD. So like, what do you pay attention to on a physical exam that might key you in on something else?
Yeah, I mean, one would just be, when they're walking to your from our waiting room to my office, just seeing how they're walking. Like, for example, like, are they short of breath when they're walking? Because they may be just saying that they have a cough, but it could be that they also have dyspnea and they're just compensating for it, which is a whole different, category. But then on the physical exam, I mean, looking in their nose to see if they have nasal polyps or irritation. Looking at the back of their throat for cobblestoning or not, which might help you with postnasal drip. And then, of course, the standard lung exam, listening for wheezing or rhonchi or rales. And one of the things that I also will do is have them do a forced exhalation. So tell them like that they're blowing like a birthday candle out. And then sometimes you can pick up wheezing that way, which is sort of like a poor man's spirometry, I suppose.
Do you just listen by, do you put your stethoscope over their trachea when you do that, or listen at their lungs, or you just listen?
Listen at their lungs.
Okay,
yeah, like various points in their lungs. Yeah.
Okay, got it.
And then, of course, we look for clubbing. And I think that's most of the relevant physical exam for the cough.
And I just have to bring this up as I think this is like a tertiary, like a fourth line thing, but the looking in the ear for earwax and cerumen impaction as a potential cause of cough is something that I came across, and I was just like, is this a real thing? Like, I have never heard of this. And are you looking in people's ears, like thinking like, oh, there's a ball of wax in there and that's what's causing their cough?
No, but I think that I think what you're talking about, I think it's called like Arnold's reflex, I believe.
I don't know. Yeah, maybe.
Where there's like crosstalk between some of the like nerves in your ears with triggering a cough. So I think when you put the otoscope in their ear, you can trigger the cough in that way. So I don't think it's necessarily related to wax itself, but
okay. So what would be the next step? So we've done our physical exam. We've taken a very thorough history, especially about the environment and any exposures, lifestyle things. So what would be the next thing that you do for this patient? Let's assume they've had a chest x-ray and that was unrevealing. And probably by the time they get to you, do you think in primary care we should probably do chest X-ray, spirometry, or is there any other tests for a patient like this? Because I think we're gonna call this guy has no real clear, let's say the history and the exam, we can't really pinpoint anything to cause his cough. What would be the basic testing that we should get?
I mean, I think a chest X-ray is helpful, of course, because if there's something abnormal there, that could help us forming a differential diagnosis. Or if it's clear, that also helps us, think of things like asthma or just airway disease. And then pulmonary function testing, if you're able to do spirometry, I think is really high yield. I don't think you necessarily have to do a whole pulmonary function test, like including the lung volumes and DLCO, because the spirometry itself is helpful just to see if there's obstruction, like is this asthma or COPD? And if it's not, then we might order, more advanced pulmonary function testing. So I don't think that you have to do the whole shebang, but, if you do, we're always happy to look at it. And so those are the things that I think when they come to me that I would look for. And then things that I might do afterwards, I think it depends on, the history. So I might, if I'm thinking that this is something related to allergies or an allergic condition, like in their environment, including mold exposures, I might do, a CBC with differential looking for eosinophils. An IgE level can be very helpful, both for allergic conditions and fungal or mold type conditions or aspergillus. So I often will check those. And then at the same time, I do send an allergy screen in their blood, which is helpful, one, from a practical standpoint. So if they end up having like severe persistent asthma and you wanted to use biologic medications, they need to have a positive allergen test also to get it covered. And so it's annoying sometimes to have the patient come back to then just do allergy testing. So oftentimes I'll do it just because if that's where we're going, we may need that. But it also helps give an explanation. So if, their allergy screen comes back positive that they have an allergy to dogs, they may have to get rid of their dog. But, if it comes back positive that they're allergic to elm trees or something, you can't really avoid that. But it helps us explain, what may be going on. So those are some of the lab tests that I would look for. And yeah, I think that's the basic things that we would start with.
I wanted to just ask about some things that I've read about but haven't necessarily done myself. So the methacholine challenge or the bronchoprovocation challenge. So spirometry you talked about, that really is just like your FEV1, your forced vital capacity, right? They may or may not do like the bronchodilator response with that, I imagine. But
right,
what's
yeah.
what do you adding a challenge to that with like methacholine? Is that something that you find helpful in actual practice? And the other one that was mentioned is this exhaled nitric oxide, which is a test I've read about but haven't actually seen ordered.
Yeah. So the spirometry will give you the flow volume loop. And so sometimes just looking at the shape of it. So if there's coving there, it might suggest that there's airway obstruction. And so they may respond to albuterol. And then if they had a normal flow volume loop, though, then you might want to do methacholine challenge test, which is just a series of pulmonary function tests and giving them irritants at different concentrations and comparing it to the normal to see if you can sort of induce asthma in them. And so we don't usually do that in people if we suspect that they have severe asthma, because obviously we wouldn't want to put them at risk for it. But if it's somebody who has normal spirometry to start with, then it's helpful to see if there's a change at a concentration that is more sensitive than the normal person.
Got it. I see.
And this may be case specific, but when do you pull the trigger on the methacholine challenge? Do you have to have some baseline clinical suspicion for asthma, or is that just when you have no idea what's going on and you're just kind of throwing spaghetti against the wall and seeing what sticks?
I haven't done it very often because I don't find it that helpful, because I think oftentimes the patient's going to end up getting probably a trial of an inhaled corticosteroid, which is really the gold standard of, do they have some sort of asthma or airway obstruction or eosinophilic asthma or respiratory disease. Like they're going to get an inhaled corticosteroid. And if they improve with it, then it makes the diagnosis. So going down the diagnostic route of doing all these different tests, I don't know if it's always helpful, because in the end, they often end up getting the same treatment anyway, and we see if it worked or not.
Okay. So we talked about testing. To summarize, probably from the primary care standpoint, probably a chest X-ray and just plain old spirometry would be a reasonable thing for us to delve into before we send them to you. I probably wouldn't, I guess you could send allergy screen or some of that other stuff from IgE or an IgE, but I just feel like a lot of the times I'd leave that to the specialist that I'm referring to. And as primary care, if we're seeing this person, I think it would make sense for us to maybe try to treat some of these most common causes first. Is there a particular order that we're supposed to go in, or does it just based on your clinical suspicion, try to treat GERD, upper airway cough syndrome, and the cough variant asthma? And then if that doesn't work, then we send them to you. Can you talk a little bit about how we might approach that if we're taking the first crack at this person with like idiopathic cough?
Yeah, I mean, I think that if the history doesn't point you to one of those three, then I often would go with upper airway cough syndrome or postnasal drip. And so using an intranasal steroid or sometimes just antihistamines can be helpful for the patient. And then, if it doesn't work, then you can refer them to me. And if you had already done that, then I might try, giving them the treatment for GERD. And if that doesn't work, and I don't feel like that there's cough variant asthma, then we might start thinking about the other rare causes. But if you started one of the three treatments, then I, might do the next highest thing that I suspect. So I think, I don't think you can really go wrong, but I would go with treating postnasal drip to start with.
So just real quick clarification question. When you say antihistamines, do you mean oral or intranasal antihistamines?
You could do one or the other. So depending on if they have, mostly I would give them just oral antihistamines. And so I don't have a lot of evidence, though, I think, to back that up to say why that versus intranasal antihistamines, just I don't have a lot of experience with them.
And I think the old chest guidelines, like the ones from 2006 on chronic cough, mention antihistamines, like the first generation antihistamine and a decongestant for upper airway cough syndrome. And I'm just thinking about like my 75-year-old patient and just thinking about, I don't really feel safe giving that treatment to them. So I like your approach better. I'm not sure if you've actually tried to follow that guideline and give like decongestant, and because
no, because I mean it all seems like a bit especially because a lot of us have elderly patients, it's hard to deal with the side effects. And I think they also recommended like first generation antihistamines, and patients are really lethargic with that. And so I don't know what's better if you're coughing or if you're lethargic. I'm not like right. Trading one thing for the other. I don't know what's better. So
I was thinking about that, and we'll talk about gabapentin, but I can't help but wonder if you're just making them sleep through their cough. Like you're just blasting someone with diphenhydramine. Like they're like, I guess I feel better. I don't know, I'm sleeping at night. Like it's
or like a lot of codeine,
Right.
I think the other thing that's really interesting from those guidelines, and I wanted to know your experience as well, is it seems like it takes a really long time. It's not like you give the person the treatment and in 3 days they feel better. Like even if you guess right, it seemed like they were suggesting that you give it like weeks to months before you give up and say that didn't work.
Yeah. So, I mean, it's really like that's why I set the expectations with the patients ahead of time, is like, we're in this for the long haul. So like, let's get to know each other because this is going to be a period of time. And so I often do like 6 to 8 weeks of each trial. If they're not successful, and it's like a test of will, if they're really bothered by this cough and they really want to figure it out, I'm going to keep going with them, but it's like whoever gives up first, I guess, sometimes. But, there's some that are really tough it out and we keep going all the way to bronchoscopy. But
yeah. Oh, man.
I mean, I don't know if that sounds like the...
It's just a grim thing. You're just like, the person has this, pain in the ass cough. And you're like, if you could stick with me for the next 3 to 6 months, we'll figure this thing out.
Right.
Yeah, it's like
but
a
also
test of will.
It's only going to get worse. Like if we don't figure it out, next comes esophageal manometry, and we're also going to probably do bronchoscopy. So this is only be more uncomfortable for you as we go.
So we really try to just wear them down, so that they just accept it, and then I'm successful.
One test I wanted to swing back to for the cough variant asthma and the non-asthmatic eosinophilic bronchitis, there's mention of the exhaled nitric oxide. And then also for the eosinophilic bronchitis, the sputum eosinophils. Are either of those tests useful in clinical practice or necessary? Because it seems like we're just empirically treating people, so maybe it doesn't matter.
I mean, I think that we have those available in my office, and I never order them. So I think that I don't know, if that says that they're helpful or not, or it's just my approach. But I think that the thing is, if their eosinophils are positive, they're probably going to get an inhaled corticosteroid. And if they're not, they're probably going to get an inhaled corticosteroid. So again, it doesn't really change that much. So I don't think it's that helpful in this specific case.
What's the duration for the eosinophilic bronchitis, which I can't say that I've seen? Well, if I've seen it, I didn't know that I've seen it. Is that something that, like asthma, where they might be on inhaled steroids for like the rest of their lifelong, or at least intermittently throughout the rest of their life? I'm just not sure.
Yeah, I mean, I think it depends on what is the trigger too. Like, is there something allergic in their environment that's triggering this? And so if they move to a new job and it happened to be something that was at the old job, they may not require that lifelong. But I think always also telling them, we'll always try to step down therapy, which is an important part of asthma therapy. So, if you're on an inhaled corticosteroid, are we able to go down, and just use a beta agonist intermittently, or just use an inhaled corticosteroid, maybe a couple months of the year. So it doesn't necessarily mean like a lifelong commitment to, to an inhaled corticosteroid.
Okay, I like it. So if they get rid of their damn bird and their cough goes away, then they might not need inhaled steroids for the rest of their life.
Right.
We're a cat show, Paul, so I guess it makes sense that we don't like birds.
Yeah, no, I feel like that follows. It's on brand for us, which is good.
I apologize to all the bird owners out there. I can just see the angry, emails rolling in. I really have nothing
literally
against.
staring at me with evil eyes right now.
I really have nothing against birds. All right, so let's check in again. This for Mr. Wheezy. Let's say that we were a really enterprising primary care physician, and we were actually treating this guy for 6 months before he got to you. So we treated him for upper airway cough syndrome. We gave him inhaled steroids, intranasal steroids, maybe some antihistamines from time to time. He was, and we also gave him like some oral steroids. We thought maybe he had like an asthma exacerbation or something. We gave him PPI for 6 to 8 weeks. And we did the spirometry, chest x-ray. We really haven't found anything. Now we're sending him to you. So what's like this next line of testing that I imagine at this point, and correct me if I'm wrong, one of Paul's questions in pre-recording is like, when should we refer them to you? At this point, I could tell you I'm going to refer to you because I don't know what's next.
Yeah.
But should we have done it sooner?
I mean, I think it depends on your comfort of treating it, right?
Okay.
Like if you're able to go through this algorithm yourself and you feel comfortable with it, then I don't think you have to refer. But I think if you did, I don't think anybody would, if you referred earlier in this, I don't think anybody would see it as a wrong thing or, laziness or anything like that. I think it would be appropriate to refer them if you've tried, some of the common treatments and you're not sure what's going on, or if there's anything about it that seems not quite right and you're worried about something in particular. I think always referring them, an easy consult is an easy consult. And so if it's something, easy for me to get done with, it's not that bad. It's a lot different than when you're in residency and everything is annoying. Like if it's an easy consult, I'm happy to do it.
Yeah. Like in residency, when you call the consultant and they give you like the long sigh on the phone, or they ask you some like really angry follow-up questions. Yeah. I remember that. I remember those days.
Yeah.
Birds specifically. I get I feel like in my own practice, I probably, it sounds like I jump a little bit to cross-sectional imaging probably too early. And rather than sort of exhausting other workup first, when do you reach for the CT scan for patients?
I mean, I think if you had referred them to me, Matt, like when you were talking about going through everything that you've already done, and they have a chest x-ray if the chest x-ray has something abnormal on it, they're probably going to get a CT scan. But if they had a normal looking chest x-ray and all of these problems, I still would probably do a CT scan, after talking with them. And because we would be looking for maybe interstitial lung disease that we're not picking up on the chest x-ray itself, and if they hadn't had full pulmonary function tests yet. So I would probably do both of those things. So a CT scan doing inspiratory and expiratory images are helpful because it can show air trapping, which, helps us know that there's small airways disease. So oftentimes when I order a CT scan, I often order it with both of those inspiratory and expiratory views. And then a full pulmonary function test, so including the lung volumes and the DLCO. So that's probably where I would go next, after he had all of these things done.
Who's getting bronchoscopy?
The ones that stick with you for 6 months.
Yeah. So,
I mean, duh.
after we've been doing this dance for, like 6 to 8 months and you're still coughing, we're probably moving towards the bronch suite. I think if they had a normal a normal CT scan and they had normal PFTs, I think the only next step would be probably bronchoscopy, just to see if there's an endobronchial lesion or something like that could be causing this. But if you haven't found anything yet on that whole workup, then the bronchoscopy might be the next step, but it's not the highest yield in chronic cough. So one of the things in terms of doing it is that, yes, you could see if there's an endobronchial lesion that you're not picking up on the CT scans, but also it kind of shows your commitment to trying to figure out the patient's cause of cough, and that you're going through a whole procedure in bronchoscopy and everything just to figure it out. And if that doesn't do it, then, we may be stuck with idiopathic cough syndrome.
If I were
NOS.
you doing the bronchoscopy, I would just have fingers crossed that I find like a sprouted pea plant in there or something. Like having people found like they thought someone had lung cancer, they've got like a cough and things, and then they find like something wedged in a bronchus down there. I imagine that's a super rare thing, but I would always be fingers crossed that that's what I was going to find. Be so satisfying.
These are like pulmonary urban legends.
Yes. So let's say you do the bronch and still nothing. I'm sorry, Cyrus, I got to read this out loud. Cyrus, our fearless producer, Cyrus Askin, is saying that he found a tooth in a right lower lobe one time. Was that a patient with chronic cough, Cyrus, or was that just somebody that you knew had aspirated a tooth?
So they may have been a polytrauma, they may have been intubated, but the fact remains that we fished a tooth out of their right lower lobe, which is pretty sweet.
That's super cool. Congratulations. High five.
Had nothing to do with cough. All right, next.
Okay, so
it would have been more exciting had you just found it incidentally, like you're working up cough and there just happened to be a tooth down there. That's still pretty.
Still cool. All right. So Brad, what are we thinking of if the bronch is normal? We still don't have a diagnosis, and we've done everything, the high res CT, all the other stuff we already talked about, and we bronch them. What is available to this person that has this idiopathic chronic cough?
Yeah, I mean, so one of the questions could be like, is this a laryngeal sensory neuropathy? So is there something about their laryngeal nerves that are hypersensitive or reacting in some way that's causing them to cough? And so this is where something like gabapentin might be helpful. So a trial of gabapentin at a low dose might help them, and that would help with the diagnosis. And I think that there's ways to diagnose that through ear, nose, and throat evaluation, like video stroboscopy and other things. But I've had a few patients that have really had benefit with gabapentin. So it makes it seem as if there's some sort of like neurologic hypersensitivity that's calmed down by the medications, because there's really no physical other explanation.
What sort of doses do you recall?
I believe it was low dose. From what I was using, I think it was like 100 milligrams of gabapentin TID. I think, is that correct?
That's the lowest, pretty much the lowest dose you can give.
Mm-hmm.
I think they recommend starting with the lowest, the daily dose starting at 300 milligrams daily, and then titrating upwards. But I don't think they're very specific as to what you titrate to.
Yeah, but I mean, it's very
until the
rare.
patient passes out.
Yeah, I mean, eventually gabapentin will stop a lot of coughing, depending on how much you give it. But it's very rare, that we would get to this point, I think, without finding any cause for this person's cough.
Right.
And then the last part of it would be like, is this a psychogenic cough? And, that's a diagnosis of exclusion, of course, because like, why is the person coughing so much that they're coming to your office when it's something that, is maybe under conscious control? But that's definitely a diagnosis of exclusion.
Mm-hmm.
And I could be misremembering, but I feel like I read somewhere in the guidelines when we're in the territory of unexplained chronic cough about fairly early referral to a licensed speech pathologist too. Is that Am I making that up? And is that something that is commonly done? Because that's not something that would have ever occurred to me, I don't think, before researching for this.
So there's like paradoxical vocal fold motion, which can be a mimicker of asthma. And it's something that they diagnose again through ear, nose, and throat evaluation and laryngoscopy. And the treatment is really a psychological treatment through speech and like the speech and language pathologists. They teach the patients how to suppress that. It's either a cough or like a wheezing that they feel that's related mostly to the vocal fold motion that's paradoxical. So that can help them in that standpoint, but it doesn't necessarily always come as cough. That's more of people who have asthma that's just refractory to all the medications. And then you start wondering, like, is there something that I'm missing that's not related to their lungs?
And there was a New England Journal review on chronic cough that Cyrus had put up, and it was talking about, the speech pathology, gabapentin or pregabalin, and then low dose morphine, like low dose, slow release morphine, 5 milligrams twice a day, which just seems like, as Paul said, you're just like, the person doesn't care about the cough at that point because they're on morphine. So is that something you've ever used or that you would recommend to the audience?
Not for chronic cough. I haven't used that. And, for other conditions, I think it can be helpful, obviously like end stage COPD or, pulmonary fibrosis or other conditions. But if we have no explanation for their cough, I feel like using opiates, like at what point would we stop then? Mm-hmm. Like if they're coughing all the time and then like I guess it just gets into a territory that might be uncomfortable. So I think sometimes people will give codeine, for a period of time. And if the patient gets better, especially after their post-viral cough, has gone away, like a one-time prescription of codeine just to sort of get through the coughing period. But usually I don't think anybody would want to keep somebody on opiates for a long period of time without any discernible explanation for it.
Yeah, that reminds me, and I think they get used all the time. I imagine you have some sort of a thought on this. Guaifenesin, dextromethorphan, you mentioned codeine, there's promethazine in codeine, there's benzonatate, which is a respiratory tract anesthetic. There's all these cough and cold formulations out there, and I see patients on them that have chronic cough. I doubt people have gone through this big thorough workup that we've talked about, but do you find that there's a role for those medications, those just sort of symptomatic cough meds that we all probably prescribed at one point in time?
No, I know. I mean, you would think like as a pulmonologist, like I have a favorite mucolytic or something like that, but I really don't. And what I usually tell the patients is if you go to any Walgreens or CVS or whatever, half of the store is cough remedies. So that should tell you that none of them are effective. Because if there was one that was effective, it would be like a small shelf of just 2 to pick from. But instead, there's like a giant market. So I think it's because none of them are effective and people just cycle through all of them. So sometimes patients will say, guaifenesin helps me or dextromethorphan has helped me in the past. And sure, like if they want to try that again, I think it's fine. But I typically don't prescribe them because I don't feel like any of them were that effective.
It's got to be a multi-billion-dollar industry. And pediatrics, there's actually some statements I've seen saying like you should not use those in pediatric patients, like specifically because in kids, I think it's a little bit higher stakes. And you could probably argue the same about the older adults that we talked about earlier in the show. And I've said this on past episodes. I don't think anybody has an incentive to really study that. Like certainly not the people that are making those agents, because people are just buying them. It says cough or cold treatment on there, and so people buy them out of desperation. So I don't know that we can fix that on this one, guys. But thank you for.
No, I feel like there's some sort of like economic, study behind it, but it's just I don't usually recommend any of them because I don't feel like any of them are particularly helpful, and it seems all like a money-making scheme a bit.
It would be a breath of fresh air if you could clear that up.
Well done, Stuart. I think he's been writing that for the past 45 minutes. Brad, this has been awesome. Thank you.
For the listeners at home, Stuart's doing a victory lap. Just so you can't see it, but it is.
Brad, thank you for talking us through these very murky waters and giving us your expertise. Can you recap some of the bigger points that you'd like the audience to take away from this?
Yeah, I mean, I think that just knowing that chronic cough, one is that it can be disabling to a lot of people. And so, even though we're joking about it, trying to take it seriously because some people it's very distressing. But using a stepwise approach and knowing the top 3 causes of chronic cough and sort of trying to hone in on one of those 3 things and treating it. And if there's no treatment for that, either upper airway cough syndrome or cough variant asthma or acid reflux, then referring to your friendly local pulmonologist is reasonable to try to figure out, what could be causing this. And just that it's a long haul.
Awesome. Brad, is there anything that you wanted to plug? We usually give our guests, you don't have to plug anything if you don't want to, but is there anything that you'd like to plug for the audience?
I mean, other than I would like to say that, one of the things when I'm rounding with the residents, because I feel out of touch, old person to them now, is telling them that I was once your and Paul's senior resident. I feel like I'm connecting to the youth of today. So
yeah.
So just letting you guys know that, there's a lot of fangirling that goes on when they know what a formative role I played in your education, I'm sure.
You did. Thank you. Thank you for being...
Credit all to you.
Yeah. Thank you so much. All right, Brad.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Paul, because we're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or contact us at thecurbsiders@gmail.com. Special thanks to our producer for this episode, Cyrus Askin, and to our social media team, Beth Garbs, Garbatelli on Twitter, Maddie Mad Dog Morgan on Instagram, and Chris the True Man Chew on Facebook. Until next time, I've been Stuart Kent Brigham. Good night.
Yes, big thanks to Cyrus for writing and producing this episode, and I believe to Dr. Kate Grant for doing the artwork for this episode. Until next time, I've been Dr. Matthew Frank Watto.
And I am, and hopefully always will be, Dr. Cyrus Askin.
And we would be remiss if we did not thank the great Stuart Brigham for composing the theme music you're doubtless hearing behind you, and we should also thank Clair Morgan of Notterly for editing our audio. And as always, our main Dr. Paul Nelson Williams, thank you and goodbye. And a gentle reminder that this and most episodes are available for free CME credit for all healthcare professionals at curbsiders.vcuhealth.org. All you have to do is create an account.